Welcome to this video on the resuscitation of the shocked patient. I am Dr. Nasser Hassan, and we will be focusing on advanced hemodynamic principles specifically designed for emergency medicine fellows. Shock is fundamentally defined by global tissue hypoxia and cellular metabolic failure rather than just low blood pressure. It is a critical imbalance between oxygen supply and demand that, if not addressed, can lead to irreversible organ dysfunction. Occult shock presents a dangerous pitfall where macrohemodynamics appear normal despite ongoing tissue hypoperfusion. Early recognition through indicators like unexplained tachycardia, altered mentation, or rising lactate levels is essential for timely intervention. We categorize shock into 4 physiologic states to guide treatment: distributive, cardiogenic, hypovolemic, and obstructive. Understanding these categories allows us to apply targeted resuscitation strategies for each specific patient presentation. Intravenous fluid therapy requires precise stewardship. The era of liberal fluid administration is over. We now emphasize dynamic testing, such as passive leg raises, to ensure we only provide fluids to patients who will truly benefit. Early initiation of vasopressors is often necessary to restore perfusion. Norepinephrine remains our first-line agent. Other options, like epinephrine for anaphylaxis or cardiogenic shock, and dobutamine for its inodilator effects, should be selected based on the specific clinical context. For refractory shock cases, we must look beyond standard catecholamines. Therapies like vasopressin for its V1 receptor effects, corticosteroids to address insufficiency, and angiotensin II can provide the necessary support when standard approaches fail. Modern hemodynamic assessment relies on point-of-care ultrasound. Tools like the Rush exam, LVOT-VTI for output estimation, and VEXIS for congestion grading represent the gold standard for guiding our resuscitative efforts. In obstructive shock, survival depends on the rapid reversal of the mechanical barrier, whether it is a pulmonary embolism, tension pneumothorax, or cardiac tamponade. Fluids and pressors here are merely bridges to definitive surgical or procedural control. To master resuscitation, we must avoid cognitive biases like anchoring on a single diagnosis. We also must remember that fluid tolerance is not the same as fluid responsiveness, and always prioritize resuscitation before intubation to prevent cardiovascular collapse. Our management follows a systematic, phased approach: salvage to restore pressure, optimization of output, stabilization, and finally, de-escalation. This framework ensures we are providing safe and adaptive care throughout the patient's journey. In summary, mastery of shock resuscitation requires a physiological, individualized, and dynamic approach. Use POCUS, practice strict fluid stewardship, and always look for the underlying cause to guide your interventions.